Good morning, all. At the outset, I would like to thank the organizers of the CME for giving me this opportunity. And going to my topic, diabetic retinopathy, catch them early. I'll be discussing the common screening criteria, the presentation of diabetic retinopathy. So, as we all know, diabetes mellitus is now considered to be the global epidemic with around 400 million diabetics in the world. And coming to India, the prevalence varies from 5 to 16% at present. And in a study by ICMR in 2023, it is estimated that 10.1 crore individuals in India have diabetes. And coming to Kerala, we have very high prevalence of diabetes, with some studies suggesting as high as 20 to 24%. That is, 1 in every 5 person is having diabetes, and the average age of onset of diabetes in India is 42.5 years, which is considered to be among the productive years of our life. And the prevalence of diabetic retinopathy is considered to be 12.5%, out of which 4% is having vision-threatening diabetic retinopathy. And average of 20% of patients with type 1 diabetes, type 2 diabetes have any form of retinopathy at the time of diagnosis, and when it is 15 years over the diabetes, the 78% of patients will be having any form of diabetic retinopathy. There lies the importance of a comprehensive eye examination, and which can result in early diagnosis and treatment, and thus reduce the burden of vision loss from diabetic retinopathy. In a study by Shankar Netralaya, that is SN Dreams 2 study, the 4-year incidence of retinopathy in any diabetic is 9.2%, and those who had no diabetes at the time of no retinopathy at the time of diagnosis of diabetes had a 2.6% chance of developing DME after 4 years, which is increased to 11.5% in those who have diabetes at the time of diagnosis. And also those who had no retinopathy at the time of diagnosis of diabetes had 5% chance of developing sight-threatening diabetic retinopathy by 4 years, which is quadrupled in cases of patients who had any stage of retinopathy at the time of diagnosis of diabetes. Coming to the wider aspect, the presence and severity of retinopathy is a significant risk factor for cardiovascular complications, and the presence of any grade of retinopathy double the risk of CVD in type 2 diabetics and quadruplicated in type 1 diabetic patients. So, whom to screen? All people with known case of diabetes on treatment has to be screened, and it is also suggested that a single record of random blood sugar more than 200 or glycated hemoglobin level more than 6.5 degree has to be screened for diabetes, and gestational diabetes, when first notified, has to be screened. And when to screen? As we know, any person with DM has risk of developing retinopathy, so those individuals who have type 2 diabetes should undergo screening of retinopathy at the time of diagnosis. And in type 1 diabetes, it is recommended to start screening after 11 years of age, that is around 2 to 5 years of duration of diabetes. That is according to the International Society of Pediatric and Adolescent Diabetes Guidelines. And diabetic women who are planning pregnancy, first screening has to be done prior to conception and follow-up screening during the first trimester of pregnancy. This is a flow chart, and if after screening, if there is no retinopathy and the patient is having good systemic control, we can screen after 1 year, and if the systemic control is poor, it is ideal to screen after 6 months. And if diabetic retinopathy is present, we have to refer to the ophthalmologist. And where to screen? Any ophthalmology clinics, hospitals, and primary eye care centers, tertiary eye care centers, etc. can be screened, and opportunity screen can be done in physician clinic, diabetes clinic, labs and pharmacy. Then community screening using camps, mobile vans and primary health centers, etc. can be done. And how to screen? That is a stereoscopic fundus examination or photography through the dilated pupil with the fundus photo covering all the 7 ETDRS subfields has to be done. Coming to the type of fundus camera, there are mydriatic and non-mydriatic fundus cameras, handheld fundus cameras, and smartphone-based fundus cameras are there. And the classification of retinopathy, according to the ETDRS classification, it is broadly non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Non-proliferative is again divided into very mild or mild, moderate, severe, very severe. And proliferative retinopathy into non-high risk proliferative diabetic retinopathy and high risk PDR. Coming to the clinical features, NPDR is characterized by presence of microaneurysms, intraretinal hemorrhages, vascular changes, hard exudates, cotton wool spots, intraretinal microvascular abnormalities, retinal edema. And in proliferative retinopathy, we also have neovascularization of optic disc and neovascularization elsewhere and associated complications like vitreous hemorrhage, fibrosis, retinal detachment, neovascular glaucoma, etc. So this is a normal fundus with normal disc and macula is normal. Then we have very mild NPDR. Here you can see in the inferotemporal area, few microaneurysms can be seen. No other changes are seen. So it is mild NPDR. Then in moderate NPDR, we have retinal microaneurysms, dot and blot hemorrhages, presence of hard exudates, etc. And we can also get macular retinal thickening, which can be away from the fovea. Here we can see supratemporal retinal thickening with hard exudates. And on OCT, we can see the edema is away from the fovea. Also, it can be, retinal thickening can be involving the centrofovea, such as CSME with here we can see the altered foveal contour due to the retinal edema. Then we have severe NPDR, which is characterized by all these dot and blot hemorrhages, exudates, presence of cotton wool spots and etc. And very severe NPDR where we get this intraretinal microvascular abnormalities and venous changes are noted here. And then we have proliferative diabetic retinopathy, which is characterized by presence of neovascularization elsewhere. Here in inferotemporal area, we can see the new vessels. Then proliferative diabetic retinopathy can also present with vitreous hemorrhage. Preretinal hemorrhage can be seen supranasally, then with fibrovascular proliferations. So coming to the imaging. For the treatment decision and follow-up, imaging is an indispensable tool in diabetic retinopathy, and imaging include optical coherence tomography, fundus fluorescein angiography, OCT angiography, B-scan, wide field imaging. Coming to fundus fluorescein angiography, it is not a routine investigation or screening modality. It is useful in confirming the presence and extent of macular ischemia, to guide the treatment of CSME, and to distinguish retinal neovascularization from irmas. Here we can see the altered enlarged foveal avascular zone, which is suggestive of macular ischemia in the first image, and in the second image we can see leaking microaneurysms, which can result in focal leakage or diffuse leakage in late stages. Coming to optical coherence tomography, it is a non-invasive technique which correlates with the retinal histology and is helpful tool for qualitative and quantitative analysis of retina, and also helps in prognostication of vision using the OCT biomarkers. And also OCT helps to identify the location, the type of edema, the thickness and volume of retina, and the reflective qualities of retina. Here, it can also help to divide the diabetic macular edema into non-center involved DME or the center involved DME. In the first image, we can see the central 1 millimeter circle is not, there is no thickening in the central 1 millimeter area and subfield zone. So it is a non-center involving DME. In the second image, we can see the central 1 mm subfield is also thickened and there is an altered foveal contour. This is suggestive of a center involved diabetic macular edema, and the management varies between non-center and center involved DME. Here also to identify the type of edema, here we can see cystoid macular edema, the blue arrow, and subretinal fluid, which is the red arrow. Then also we can identify whether the macular edema is due to vitreoretinal traction and it is secondary macular edema, in which case we have to do vitrectomy. Also, this is a diffuse edema with a normal foveal contour is normal. And here we can see the hard exudates and mild thickening of the retina. Coming to OCT angiography, it helps in assessing the changes in foveal avascular zone so as to identify macular ischemia. Also, perfuse capillary density mapping and vessel density can be assessed to know about the perfusion status of retina. Coming to wide field imaging, there is a relatively new entity called predominantly peripheral lesions, in which the features of diabetic retinopathy, that is the microaneurysm, hemorrhage, erymas, NVE are present outside the ETDRS7 field and are in greater number or extent in peripheral field. That is, more than 50% of lesions will be seen outside the ETDRS7 fields. And this is a indicator of rapidly progressing retinopathy and high risk of retinal neovascularization. And this can be identified with wide field imaging. And when to refer to a vitreoretinal specialist? When there is diabetic macular edema or tractional edema, when the visual acuity of the patient is not corresponding with the retinal findings, when there is proliferative diabetic retinopathy which needs panretinal photocoagulation, when there is vitreous hemorrhage which is persistent or recurrent, or when there is tractional retinal detachment which is involving or threatening the fovea. Coming to the follow-up schedule. After screening, if the fundus is normal, we can follow up the patient annually. If there is mild NPDR, the patient can be followed up 6 to 12 months interval depending on the presence or absence of diabetic macular edema. And in moderate NPDR, if there is diabetic macular edema, we have to follow up the patient 1 to 4 months based on the type of the edema, that is whether it is center involving or non-center involving. Center involving edema needs frequent follow-ups, that is around 1 month to 2 month follow-ups. And if there is no diabetic macular edema, moderate NPDR patients can be followed up in 6 monthly intervals. And in case of severe NPDR, if DME is present, 1 to 4 months, and if there is no DME, we can review the patient at 4 monthly interval. And in PDR, 2 to 3 month follow-up is needed. And in case of diabetic macular edema, as already said, 1 to 4 month interval based on the type of edema, whether it is center or non-center involved edema. So to conclude, as ophthalmologist, it is essential to ensure timely detection of any stage of retinopathy and sight-threatening retinopathy, and to form appropriate protocols in place for prompt treatment. And we have to educate the individuals with diabetes regarding their eye status, and referral to physicians for control of the risk factors and other associated complications of diabetes has to be done. Thank you.